back to Tuesday Tips with Dr. Vidal here at Pure Plastic Surgery. This is our weekly check-in discussing different topics in plastic surgery and answering your questions. Today we're going to be talking about breast reduction and breast lift, what it includes, what's the difference between the two, why do this procedure, what goes into the procedure itself, a little bit on the post-op course and complications of the procedure, and then we'll take some questions, okay? So we'll start with what's the difference between the two procedures. Basically, your goal, right? So if your goal is to reduce the volume of the breast, then that's a breast reduction. And we'll talk a little bit about what are the symptoms associated with large breasts that usually make a patient choose to have a breast reduction. A breast lift is just lifting the breast, so it's reshaping it, putting the nipple position back in the center of the breast, but without removing too much volume. So most of the time, patients want to keep a similar volume or even go a little bit bigger. They just want to have the shape improved. So those are basically the two differences. But the incisions pattern, so that the incision itself is very similar. Most of the time the same, depending on the degree of droopiness. So we'll talk about that. So breast ptosis is the medical term for breast droopiness, okay? So depending on how much droopiness or ptosis you have, it's usually the incision pattern that we have to do to reshape or reduce the breast, okay? So there are 3 degrees of ptosis, okay? This is looking at a breast. This is my beautiful diagram. Looking at the breast on a side view, okay? So this is the breast, this is the nipple, and this is the inframammary fold, okay? So the fold below the breast, okay? So whenever the nipple is above the IMF, in the center of the most projecting part of the breast, that's no ptosis, right? That's the normal breast shape, okay? When that nipple starts to droop and it's at the level of the fold, that's a grade 1 ptosis, okay? When it's lower than the fold, but it's still not in the most dependent part of the breast, that's a grade 2, and it's usually the most common degree of ptosis after weight loss, time, gravity, and pregnancies, okay? Grade 3 is when the nipple is pointing down completely. So if you're looking yourself in the mirror and your nipples are in the most dependent part of the breast or pointing down, that's a grade 3 ptosis, and yeah, it's also below the level of the fold, okay? So these are the 3 grading system for breast ptosis, okay? You can have it with only breast ptosis or breast ptosis and macromastia. What's macromastia? Macromastia is just large breasts, okay? So that is why breast lift and breast reduction are very similar in terms of the incision pattern, but the difference is the goal. What are we achieving at the end of the procedure, okay? So macromastia is the medical term for large breast, okay? What are usually the symptoms with large breast? Very common is this bra strap grooving. They get so heavy that patients start to get a fold there because it's too heavy on their shoulders. Very common, they have neck pain, shoulder pain, upper back pain. They can develop rash because the breast is heavy enough that is laying all the time over the skin. So they can develop rashes underneath the breast that's in the fold itself, especially in humid environments, especially in the summer, okay? And the other area that is very common to develop problems is getting a bra to fit. So most of these patients need to get custom fit bras to fit their breast. They're tired of the heaviness of all these symptoms. And the goal of the procedure is to make them smaller, okay? And obviously improving the shape because those go hand in hand, okay? So that's usually the symptoms that we see with large breast. Breast reduction is actually one of the procedures in plastic surgery that's associated with the best and the most patient improvement and patient satisfaction. Because usually these patients are tired of carrying that heavy weight literally on their shoulders. and feel a lot better afterwards, okay? The incision types will depend on the degree of ptosis, okay? So a donut lift or a periareolar is an incision that's only around the areola. This, it's not going to reduce the size of the breast significantly, so it's not really for patients that are looking for a breast reduction. It's more for patients looking for a breast lift only, because, like I said, the shape is going to change, but not the breast volume itself, which is the goal of a breast reduction, okay? So patients that are a grade 1 ptosis, very minimal degree of ptosis or droopiness, the nipple is at the level of the fold. If you're looking at yourself in a side view, they're candidates of doing a donut lift. The donut lift itself will improve the shape, the position of the areola in the breast, but not that much the shape of the entire breast, okay? Usually when I combine a donut lift, when I do a donut lift, I usually combine it with a breast implant. This way you change the shape of the breast because you're adding volume and rounding the breast. And with the donut lift with a grade 1 ptosis, that combination of a periareolar and an implant usually gives a good result, okay? Lollipop, it's usually for patients either grade 1 or grade 2, but very minimal grade 2, very close to the fold. If it's too far off of the fold, then you're gonna need an anchor, okay? So lollipop, it's a type of incision that it's very restricted in terms of the patients that qualify or will improve the shape with this, okay? The type of reduction that you can do is very minimal because you're only removing breast tissue from the center of the breast, not from the sides. That usually, and you can see here, the breast usually grows not only down, but down to the sides when it gets big. And to kind of remove breast tissue from the side and the center, you have to do an anchor type. With the lollipop, you're only going to remove tissue in the center. Also, with the lollipop, you have a limit of how much you can raise the nipple. It's usually not that much. And you're not bringing the breast in. You're just lifting, okay? So those are the limits of the lollipop. Usually, I don't use it a lot because it has a lot of limitations in terms of reshaping the breast. Has to be like the right candidate, right breast, and it's basically a patient with a grade 2, very minimal grade 2 ptosis, not wide breast, very narrow breast that only need a little bit of a lift and tightening on the bottom, okay? The most common type is the anchor type because the most common type of ptosis is grade 2, that is a little bit more droopy. In anchor type, it's an incision around the areola, down and across. How long is this across? It depends on how much droopiness you have. Sometimes, it needs to go from all the way here to all the way lateral, but as you can see in her, it hides very well on the fold. That incision in the bottom, most of my patients are scared of the incision in the bottom, but because the breast kind of droops a little bit, that's the natural shape of the breast, that incision in the bottom, you can barely see it unless you lift your breast like that, okay? So the incision is around the areola, down and across. That allows me to lift the nipple position to put it in the center of the breast instead of her that it's low. This is her fold, so the nipple is lower than the fold, okay? So she has a grade 2 ptosis. The fold you can see up here and the nipple is down here. Allows you to lift it and also reshape the breast, making it rounder, okay? And this is her result. You see I lifted the nipple in the center of the breast and also rounded up, okay? The incisions usually hide very well. Patients are always scared about that many incisions, but because the areola one, it's hidden in the change in pigmentation between the areola and the skin, usually heals very well, and you can see on her that you can barely see that incision. The one in the vertical is the one that you're gonna see, but it's usually on the bottom part, on the dependent part, so just a thin line. And then the one in the fold is very well hidden because of the gravity of the breast, okay? And she was very happy to get that weight off her shoulders, smaller, lifted, procured look, okay? What are the most common complications with this procedure? Before jumping into the complications, basically the procedure itself, if you're just doing a breast reduction or breast lift, it's a procedure that lasts for it takes like an hour and a half, 2 hours to perform. At first, you're gonna have little tapes over the incisions. Those are called steri strips to cover the incisions for the first 2 weeks, okay? After 2 weeks, I'm gonna ask you to remove those little tapes so you can start scar treatment, okay? The use of scar treatment is very important, especially on surgeries that require a lot of incisions, like a breast lift or breast reduction, like a tummy tuck, okay? The product that we sell here that I recommend is called Incision. It's very good because it's 100% silicone, okay? The important part of the scar treatments, you see, there's a lot of different products with scars. You can go online. The important component of a scar treatment should be silicone. That's the only thing that has been proven in studies to improve the appearance of the scar, okay? To get it thinner, to get it lighter, okay? There are a lot of different products, vitamin E, other products, a lot of different components, but the only one that has been proven is silicone. So when you are considering buying a scar treatment, make sure that you're buying the correct one, okay? This one has 100% silicone, so it's basically silicone itself. So, and that's the proven benefit, okay? It comes in 2 forms. Usually the silicone scar treatments come in 2 forms. One is the gel that you apply over the incisions twice a day. And the other one is a tape that you put over the incision and you leave on the entire day. So 23 hours a day, just remove for shower, okay? Both are equally effective, is whatever is more comfortable for you, okay? So you decide if you want to use the gel or the tape, okay? So scar treatment after 2 weeks, the only thing I'm going to ask you not to do for the first 2 weeks is elevate the arms above your shoulders, okay? So the post-op team call it T-Rex arms to keep it close to your body, okay? So this, you can wash your face, you can wash your hair, that's fine, but nothing like reaching over, okay? The reaching over is just going to put more tension in the areas of healing, and you can develop wound healing problems. And that's my first possible complication is the most common after a breast lift or breast reduction. It's having wound healing problems. Put a sad face here, but complications can happen to anyone, okay? The surgeon that tells you that they have 0 complications, that is a lie, okay? There's no surgeon. Only way of having 0 complications is you do 0 surgeries, okay? If you do surgeries, you're gonna have complications. The goal is to decrease your complication rate as much as possible. So the post-op instructions and the things I'm gonna ask you not to do or to do afterwards is to try to decrease these complication rates to the lowest, okay? The other most important thing for complications is to be in communication with your surgeon very fast after you develop anything, right? You have any questions, you have any concerns, you see anything worrisome in your incisions, right away contact your surgeon. That's the most important thing. Your surgeon should be able to give you instructions and to attack the problem early on so a complication can be taken easily, fast, instead of getting more and more evolved and more severe, okay? So let's talk about the most common one, which is wound healing problems. Where the 2 incisions meet down here, we call that the triple point or the inverted T. It's an area where all the tension relies in the closure. And there are 2 incisions meeting, so 2 areas that need to kind of heal together. So it's just an area that it's prone to have wound openings, okay? That's the bad part. The good part is that it usually heals with local care. So I know it's an added stress to see an open wound in your breast after surgery, but it's nothing to be very concerned about. Usually it takes a couple of weeks to heal, but we just treat it with local antibiotic ointment to prevent infection in that area. Most of the time, that opening is not infected. It's just an opening in the wound, but it's not an infection. We treat it with the Silvadine or the antibiotic ointment to prevent getting infected, okay? So you should treat it with that. that gauze changes, takes a couple of weeks to heal, but usually heals on its own, okay? The other possible complication is infection. Whenever we do an incision in our body, there's a risk of having an infection. It's not very common with breast reductions, but we can see it. Usually, if it happens, it's a very self-limited infection to the skin that we treated with PO antibiotics or pills, okay? Not in the hospital setting, as outpatient. The important thing is just let us know. We'll ask for a picture, or if you're here in town, we'll ask you to come in, we'll take a look. I'll change the antibiotic, and usually that's it. Very, very rarely the infection progresses to a point that you'll need to get IV antibiotics, which is in the hospital, but that's extremely rare. Most commonly, it's taken care with just PO antibiotics, okay? All of my patients, I put them on antibiotics post-op, so you're going to be taking antibiotics for the first week to prevent post-op infections. I'm going to give you an IV antibiotic in the surgery before incision to decrease the complication rate of infection. And also, before closing the breast, I irrigate and clean with antibiotic solution and another antiseptic solution called betadine, okay? So those are all the things that we do to try to decrease that, but it's never zero. And again, if it does happen, it's usually treated with just pills, okay? Hematoma or bleeding, it's always also a complication after surgery. Very rare with breast procedures, but it can happen. How are you going to see or notice that you have a hematoma? It's usually in the first 2 to 3 days after surgery, one breast gets significantly larger than the other, okay? If you see that happening, you give us a call right away and we'll tell you what to do. If it's just a little bit and it's very contained and it's not progressing, we can treat it with just observation. But there's sometimes that we have to go back into the operating room to see what's bleeding, to take that blood out, clots out, clean everything up, and close again, okay? Again, very rare, but that's how you're gonna notice it, okay? And nipple necrosis is the other one. Very, very rare complication of a breast reduction or breast lift, but it's never zero, okay? Why does this happen, okay? Because we have to move the nipple, okay? Just imagine, this nipple is here, I have to kind of rotate the breast tissue to put it there, okay? Whenever we're doing that, the blood supply to the nipple comes from the chest, comes from here, the blood vessels that supply the nipple, okay? So we have to leave enough breast tissue that the blood supply is intact and the nipple has good blood supply. And also when we close, it can't be too tight that the blood supply gets basically squished and can't get to the nipple, okay? So very rare, but can happen. In few patients, when we're talking about breast lift and implants, some patients I suggest to stage it. What does that mean? We do the breast lift first, and then you come back later, 3 to 4 months after, to put the implants in. It's not very common that we have to do that, but sometimes we do, especially when patients have a grade 3 ptosis. Very low, that means that I have to move the nipple a lot to get it up there. And adding an implant is just going to add too much pressure, too much volume, too much tension to the closure, putting you at increased risk of this, okay? So if I suggest staging it, is for your safety, for your protection, to try to avoid that complication, okay? What is it, how you're going to notice this? Usually I notice it, we can notice it right away. So if it happens, I'm going to start you in creams, in pills, and medications to try to improve blood supply to the nipple right away. One of the things that we do is release some of the sutures to release some of the pressure on the nipple. And if you have an implant, sometimes we have to remove that implant, okay? Local care, ointments, those are basically the majority of the treatments. Other alternatives such as hyperbaric oxygen therapy, which is a chamber that you put the patients in with high oxygen levels to improve circulation. That's like a last resort. Usually it's not needed, but it's one of the options on the treatment of any area of necrosis, but nipple necrosis too, okay? So this is one of the patients that I wanted to show you guys. She is 3 months post-op in this picture, and you can see the reshaping of her breast from a more elongated breast to a more round, perkier, lifted breast. Nipple in the center. The areola size, I always reduce it because with large breast, the areola tends to get larger and loses its shape. Instead of being a circle, it's an oval or sometimes very irregular. So I make it rounder and smaller, proportional to the new smaller breast. Okay, the other one that I wanted to show you guys is this patient that had a breast reduction as well. Okay, very large breast. I always tell my patients breasts are sisters, not twins. Okay, so we are all asymmetric, and that's beautiful. Okay, this one, you can see that this patient had the left breast larger than the right. When I do a breast reduction, I try to match it, okay? So I remove more breast tissue from the side that is bigger, try to match them up, okay? You can see her areola, it's wide here and more like an oval instead of a circle. So areola size smaller, incision hidden very well in the edge of the areola here, down, and you can't even see the other one, okay? She is 2 months post-op in this picture, okay? And you can see on the side view, something that's very important that I always tell my patients. On breast reduction or a breast lift, the breast shape is gonna look very round and perky at first because it's swollen. Once the swelling comes down, the breast is gonna take the natural shape of the breast, which is a little bit flatter at top and rounder at the bottom. That's the natural shape of the breast, okay? If you don't like that shape or want a more perkier push-up look, then you have to put an implant, okay? If you have a very large breast like this, then I'm gonna in your evaluation, I'm probably gonna recommend to stage it, okay? The best thing is to go from this to this, have it healed, have the nipple healed in the new position, and then we can add an implant and add that push-up bra look and more fullness at the top if that's something that you're looking for. But usually this is the normal healing of a breast reduction on a side view and this on a front view, okay? I'll take some questions from you guys now if you have it.
Okay, here we're going with the first one.
Yeah.
Auxiliary underarm tissue removal, is that considered breast tissue?
So depends on where you're pointing at. So breasts, when they get very large, you tend to have a lot of side breast here, okay? So if you're talking about that area here in the bra, most of the time when I do the lift, I kind of push the breast in and that gets flattened out. Sometimes I have to extend the incision. If this is very large and hanging, the incision, this incision that goes, sometimes I have to extend it on the side of the breast to get that extra skin out, okay? Sometimes if you have a lot of fatty tissue there that it's not excess skin, then you may need to add what's called subaxillary liposuction. It's liposuction to that area or this area here. That's an add-on not included in the original or baseline breast reduction, breast lift surgery, but it is something that we can definitely combine if that is an area of concern.
Okay, the next one. How long do we have to wait until we can go back to exercising?
Exercising, I always ask you to avoid exercising and heavy lifting, which is more than 10 pounds for 6 weeks after surgery, okay? So T-Rex arms for 2 weeks and then no exercising, heavy lifting for 6 weeks.
Okay. How many post-op massages do you recommend, if any?
For breast, I don't recommend any post-op massages, okay? If you're combining this with lipo or with tummy tuck, then that's another story. But breast itself, I don't recommend massaging it. For breast implants, I might, but not at the beginning, okay? So at 2 weeks post-op, if they're very high, I'm gonna ask you to start massaging the implant pocket to try to help drop the implant. But I don't want you to be massaging the breast too early because you're putting tension on the incisions. and we can end up with having wound healing problems. Okay.
Wait, okay. Can you do implants with reduction?
Yeah, well, depends on how big is the breast, okay? So that's a very particular patient that wants some of the breast tissue removed, but wants also that push-up bra look, okay? So that's usually the combination of a breast reduction implant, okay? If the breast tissue is not that if you're macromastia, so the breast tissue are not that big, we might be able to combine. What is it that I'm going to be looking at to determine if we can or not? One is the amount of breast tissue I need to remove, and the other one is the distance from your neck to your nipple, okay? So one of the measurements I take when I see you on pre-op, take a lot of measurements of your breast, but one of the most important ones is the distance from here, from the center of your collarbone here to your breast, okay? If that distance from here to here and here to here, if that distance is more than 30 centimeters, I'm gonna advise you not to combine a breast reduction with an implant. I'm gonna ask you to stage them. And why? To decrease wound healing problems and nipple necrosis, okay? It's too much tension, too much lifting of the nipple, too much risk, okay?
Okay, can you do over the muscle without a lift with sagging breast?
So implants for breast ptosis is something that it can be done. If I'm doing breast augmentation and taking care of some sagginess with the breast augmentation, I prefer to put it under the muscle, okay? The reason for it is because there's something called a dual plane. Okay, dual plane means that I'm putting the implant under two planes, the muscle and the breast, okay? So what it means is that basically the pectoralis muscle or the chest muscle goes up to half the breast. It doesn't go all the way down. So I release the muscle partially, and then the implant is going to be behind the muscle on the top and behind the breast tissue on the bottom of the implant. And that's called dual plane, okay? Dual plane, depending on how much I release that muscle, how much I release the breast tissue on the inside, everything is on the inside, nothing that you're gonna see on the outside. Depending on that, the nipple can be lifted a little bit, okay? We're talking about patients with grade 1 ptosis, okay? If you have grade 2 or grade 3 ptosis, then you're not a candidate for a breast augmentation dual plane. For ptosis correction, you're a candidate for a breast lift implants, okay? So those patients are, yes, it can be done, but very select patients that only have grade 1 ptosis.
Do we need to compress to get rid of swelling?
So you're gonna have a surgical bra. The surgical bra, it's not a compression garment itself, but it does keep the breast in shape, in place. The swelling will happen and it'll come down. I don't want you to be compressing the breast too much, because then we end up with nipple necrosis problems. Too much tension on the breast, nipple, and problems with healing. Okay? So thank you so much, you guys, for all the questions. I hope this here helped you guys understanding a little bit about the difference between breast reduction, breast lift. What are the things that we can do with both procedures, the results that we get with those procedures, and also the possible complications. I enjoyed a lot our time together, and join next week again for Tuesday Tips with Dr. Vidal. See ya.